Okay, welcome everyone, and thank you for being here at the HWell EPIC conference. My name is Viviane Josewski, and I'm an assistant professor in the School of Nursing at the University of Northern British Columbia in Prince George, which means I'm joining you from the ancestral, traditional, and unceded territory of the Clyde Lake First Nation. I'm very honored to be here today to be chairing today's session on autonomy and independence. And I just want to take a second for those of you who are new to HWell to say welcome. HWell's vision is about Canada's leadership in technology and aging benefits the world. And to accomplish that, the mission is to develop a community of researchers, older adults, caregivers, partner, and future leaders that accelerate the delivery of technology-based solutions that really make a meaningful difference in the lives of Canadians. So here you can see that the HWell network is really incredible in terms of its size and scale because it brings together more than 300 researchers, 50 member universities and research centers, and almost 1,500 trainees, as well as partners in industry, nonprofit, government, and beyond, including also international collaborators. And perhaps most importantly, it supports more than 70 startups and actively engages more than 5,000 older adults and caregivers. So today, before we get started, I just have a quick reminder for everyone that the EPIC conference sessions are happening daily on Zoom from 12 to 1 p.m. That is in Eastern time, Tuesday through Friday, this week and next. And we really encourage you to check out the full program and attend as many sessions as you can. You'll find all the details, including the session topics and speaker bios on the EPIC conference webpage, and you can also download them. Here's what you can expect for today's session. I will begin with a short presentation to introduce the Autonomy and Independence Challenge area. And after that, we'll hear two research presentations, and each of them is for 10 minutes, and then we're followed by a 5-minute Q&A. And now we'll shift to our Moving the Dial presentation featuring a supported startup. And then we'll wrap up with a general Q&A to reflect on what we've heard and also to connect. So I'm very excited to introduce today the presenters at our conference, and that includes Ghanim Saqib and Maren Bolstler, who will present on supporting mobility and independence in older adults, a wearable-driven solution for neighborhood-specific challenges. And our second team of presenters include Natalie Todam and Gail Ramsden, who will present together towards a better approach for evaluating the comfort, dignity, and safety of transfer technologies through integrated knowledge translation. And finally, we have Emile Mamare, who will highlight how SteadyWear is moving the dial by improving quality of life for Canada's older adults and caregivers. So just very quickly before we dive in, I have a few more housekeeping notes to help you get the most out of today's session. So first of all, we really encourage you to use the Q&A box to submit your questions, comment on others, and also upvote the ones that you most like to see answered. I'll prioritize those questions during the Q&A portion. So you're also very welcome to share your thoughts or reactions in the chat throughout the session. And that's a really great opportunity for you to help shape today's conversation about how today's presentations, for example, connect to ongoing research, your own research, and other real-world issues. Also, please note that today's session is going to be recorded and that the recording will be made available after the event. You'll be able to find it on the EPIC conference webpage, as well as on the HWell YouTube channel. If you like, you can also turn on closed captioning using the Zoom toolbar. And with that, let's get started with a brief intro to the challenge area of autonomy and independence. So autonomy and independence is one of eight challenge areas that have been identified through H-Well's network. And those areas really guide the network's research and innovation priorities to improve the lives of older adults and caregivers. So this particular challenge area focuses on supporting older adults in trying to maintain their autonomy and independence even in the face of impairment, disability, or illness. So why does this matter? Autonomy and independence in aging matter because they are recognized as critical determinants of quality of life, health, and well-being. The WHO identifies them as two of the core pillars of healthy aging. So evidence, for example, shows that older adults who retain decision-making power over their lives report lower rates of depression, anxiety, improved physical functioning, as well as lower mortality and morbidity rates. But autonomy also enables older adults to engage in community life, volunteering, and social relationships, which are themselves protective for health. So it's impairment, disability, or illness that can and often do limit independence and choice in multiple and often intersecting ways, and oftentimes with quite a detrimental impact on the health and quality of life of older adults and caregivers, which really makes this question of how to best support older adults' autonomy and independence in a really important challenge area. So something else that we should consider when we think about this challenge area, and something that is often forgotten, is that autonomy and independence are also recognized human rights, particularly, for example, under the UN Convention on the Rights of Persons with Disabilities and other age-specific UN frameworks. Importantly, this means that older adults, especially those with impairments, are entitled to support that enable autonomy and independence. And they are entitled to make decisions about their care and quality of life. So a human rights-based approach really adds a very powerful and principled foundation to how we understand, design, and deliver supports for older adults. Sadly, these rights are challenged a lot, especially within the current socio-political, cultural, economic, and historical context. First of all, we see very important demographic shifts that highlight the magnitude and complexity of this challenge area. We all know Canada's population is aging. By 2030, nearly 1 in 4 Canadians will be 65 years or older. But this story is not just about numbers, it is also about diversity. Canada's older population is increasingly culturally diverse. By 2036, over 30% of older adults in Canada are expected to be foreign-born. And similarly, while First Nations, Métis, and Inuit peoples are younger on average, this population is aging too. The Indigenous population aged 65 and older is one of the fastest growing segments in Canada. So what that means is that how autonomy and independence are understood within cultures might differ. And that means that solutions must be flexible, inclusive, and culturally responsive. At the same time, we also face a number of structural and systemic challenges when it comes to independence and autonomy in aging. That includes, for example, a healthcare system that often prioritizes treatment over prevention, as well as a lack of affordable, accessible, and supportive housing options for older adults. We also know that many older adults are still excluded from policy, service planning, and research, reflecting patterns of ageism and paternalism. That said, how to balance respect for autonomy with concerns about safety, especially for those who are experiencing cognitive decline, is one of the big ethical challenges in this area. When we account for the numerous social inequities that shape older adults' lives and life opportunities, you can see how these ethical challenges become even more complex. We know that gender, class, racism, colonialism, ableism, place, and heteronormativity all intersect to create inequities among older adults that constrain opportunities for autonomy and independence for some, while they are privileging others. So it's clear that these challenges are significant, but they are also presenting powerful opportunities for innovation, opportunities in which technology can play a very important part. And some of the questions that are driving technological innovations in this challenge area today are, for example, how can we develop technologies that enable older adults to live longer independent lives and to do so with dignity? How do we design technologies that adapt to users, not the other way around? How do we balance safety with freedom and support with self-determination? Also, how do we ensure that autonomy isn't a privilege, but a right, regardless of gender, race, class, ability, or place? So, for example, how can we make age tech solutions accessible, appropriate, and available to all older adults? Part of the answer lies in co-design. So collaborating directly with older adults, caregivers, and diverse partners to ensure that solutions reflect real needs, values, and lived experiences. In Canada, age tech researchers and startups have been tackling these questions for some time now by co-designing innovative solutions with older adults and caregivers. These innovations take many different shapes and forms, and they may range from such things as smart home technologies that enhance safety without compromising privacy, to assistive technologies that are not just functional but empowering, and digital platforms and mobile apps that support self-management of health and daily tasks for older adults who are navigating cognitive challenges, and that are just a few to name. So as we look to the future, it is clear that one size doesn't fit all. So to meaningfully support autonomy and independence in aging, we must recognize the complexity as well as the diversity of aging experiences in Canada. And that really means that we need to center the voices of older adults and caregivers in all aspects of policy, design, research, and care, and that we need to reflect the diversity of their experiences, including the intersections of culture, language, identity, place, and ability. And that requires that we have to think about supporting autonomy and independence, not just as a clinical or technological challenge, but that it is a question of equity, inclusion, and human rights, which will require collaboration across disciplines and sectors to create meaningful change in the lives of older adults. And with that, I've come to the end of the quick overview of this challenge area, and I want to say thank you and then turn it over to our presenters who are leading very exciting work in this space. So first up, we have Ghanim and Maren. So please get your presentations ready while I'll introduce you. So we have, first of all, I'm just gonna stop sharing. So first of all, we have Ghanim Saqib, who is a second year PhD student at the University of Alberta. He's enrolled in an interdisciplinary program that bridges occupational therapy, gerontology, and construction management. His research focuses on creating safer and more inclusive environments for older adults by integrating principles from healthcare and the built environment. And then we have Maren Bolstler, who is the manager of housing support at GEF Seniors Housing, which is the largest low-income seniors housing provider in the province of Alberta. Maren is a graduate of the University of Alberta and the University of Glasgow. If you're ready, Maren and Ghanim, please share your screen now and take it away.
Thank you very much, Viviane. My name is Maren Bolstler, and I am the Manager of Housing Support at GEF Seniors Housing, as introduced. And together with my colleague Ghanim, we are working on a project called Supporting Mobility and Independence in Older Adults, a wearable-driven solution for neighborhood-specific challenges. And I am here to introduce GEF Seniors Housing and the organization and how we're working with the University of Alberta. So GEF Seniors Housing is the largest nonprofit social housing provider for seniors in the province of Alberta. And we currently house approximately 3,800 seniors across 41 buildings in the city of Edmonton. To live at GEF Seniors Housing, you must be over the age of 65. You must be a Canadian citizen or a permanent resident or completed your sponsorship process. And you must meet an income threshold. So we are mandated to provide housing to low-income seniors. So that means we use people's income tax notice of assessments to assess their income level, and those are the people that we house. We currently have over 1,000 seniors on our waiting list, and our occupancy levels hover around 98%. So, as discussed by Viviane, we know that our population is aging, and it shows in our housing organization here at GEF. We cater to, well, we house rather, seniors who live independently. We do not provide any clinical care in any of our buildings, so our seniors must live independently, which means they are physically, mentally, and emotionally able to look after their own personal needs with or without assistance of community-based services, so like home care or social workers, for example. They need to be independent enough to maintain their home, so their unit, in a safe and clean condition. They need to be able to live amicably with their fellow tenants within their community. And they need to be able to follow our lease agreement and our rules and our guidelines to be a successful tenant in our organization. For this project, GEF Seniors Housing, in conjunction with the research team from the University of Alberta, chose an apartment building called Strathcona Place Apartments. And it is a 227 unit building here in Edmonton. It's in an established and mature neighborhood, so big green trees and streets and alleyways, so a very typical Canadian neighborhood of about 100 years old. It has strong transit links because it's near a really main road, and it has amenities within a walking distance or by bus or by car. So one thing we need to note is that each one of our 41 GEF buildings has its own personality and characteristics. Strathcona was chosen because of its location. It's in a nice mature neighborhood, like I mentioned, and super walkable with great transit links, but also because we knew those clients would be interested in taking part in the study. These are clients who use their feet to get around, for example. They use transit. They are a very active community. So that's why we chose this building, because we knew that these clients would be interested in this type of project, but they would also be useful for the study. So that was very, very important. We did a presentation to the clientele at Strathcona, and the group was super enthusiastic. They were intrigued about wearable technology and using their phones and trying new things and how they could walk through the neighborhood and go to the bus stop and how it would work. We had genuine interest from our clients, and that was key to success of this research project. So one of the things we know as a housing organization is that as we house our clientele at age 65 or older, and as a note, most of our clients are aged between 71 and 100 years old. So 65 is super young for our organization. But we know as people age, their capabilities change. So they might have a physical impairment or an emotional or mental impairment. We become cognitively delayed sometimes. Then in combination, as our bodies are working differently, our minds are working differently, we're encountering environmental barriers that maybe weren't barriers before. So a simple step up is now a challenge, or a step down. getting in and out of the bathtub, for example, or simply walking to the bus stop because we have to navigate curbs and go up and down and around corners. Challenging. So this becomes very challenging for our clientele. Then that forms into repeated stressors. Oh my goodness, I have to walk to the bus, but there's those steps. How am I going to get to No Frills? How am I going to get to Safeway? And so then we notice that our clientele start retreating into themselves. Their mobility is decreased because they're not comfortable navigating their own neighborhood or their own home due to those stressors, those steps, those ramps, those corners. Things become unfamiliar. They become scary. And then that results in social exclusion and isolation, which is such a challenge for our clientele. If our clientele are nervous about walking to the bus stop or getting to Safeway or No Frills or to the doctor or to the community center, they stay home. And that's where we start seeing the real effects on their emotional wellness and even their physical wellness because they're simply not leaving home enough. And that's where the relationship happens with the University of Alberta. And now I'm going to pass it over to my colleague.
Thank you so much, Maren. Thank you very much for giving us a brief about what is happening with the GEF. Another aspect that I want to talk here is basically the neighborhoods. So whenever the seniors decides to go out for mobility, the first step they put is in their neighborhoods, because their neighborhoods includes the grocery stores, the parks, the drugstores, bus stops, basically all the amenities they need for their activities. Now, when the seniors have high neighborhood confidence, or they feel confident in moving around their neighborhoods, that results in enhanced outdoor mobility. Contrary to that, when the seniors are not comfortable in going around their neighborhoods, that results in social exclusions and health issues. So what we decided to do is to take the advantage of combined wearable environmental sensing framework to identify stresses that cause barriers among the seniors. What we did, first, we utilized the physiological sensors from the body, that it also includes the GPS tracking in their daily trips. The data that we collected helped us build a classifier that would classify the stress among 3 different categories, simply to say low stress, high stress, and medium stress. We pinpointed the locations where the seniors have experienced the stress. Once we have the individual stress mapping, we moved forward for the combined or collective stress mapping. Now that is where we identified the stress hotspots. Based on these stress hotspots, we developed an application which we named the Safe Commute. What the application does, it shows the participants the areas where the stresses are available. What are the mitigation strategies they could have adopted to mitigate the effect of those stresses? And again, what are the alternative routes available for them if they want to avoid those stresses? There is a very well-established approach, and it says that if you already know what is going to happen with you, you are less affected with the impact of that. For instance, we know it's going to rain today, so we'll be better prepared for that. We know it's going to snow today, so we'll probably put on our snowshoes and stuff. So we are better prepared for that. That is what we decided for the Safe Commute app. The participants, again, from Strathcona Place, thanks to the GEF, there were 26 participants who took part in the study. The study lasted for 9 weeks. The first 4 weeks, we simply collected their physiological data and the GPS tracking to develop the intervention app. The next 4 weeks, we basically tested the intervention app. For that, we used 4 key constructs, and the results were simply amazing. So we wanted to improve their neighborhood-specific mobility self-efficacy. Compared to the control group, the intervention group actually showed a significant improvement in their neighborhood-specific mobility self-efficacy. The general mobility, on the other hand, showed a slight increase because the focus was more on the neighborhood-specific effects rather than the general mobility effects. The mobility intentions was also significantly high in the intervention group compared to the control group. And again, the perceived mobility that we checked through the University of Alabama in Birmingham life space assessment was also significantly high in the intervention group compared to the control group. With all these measures in hand, this application proved to be a very good starter for the seniors to go out, know what is going to happen with them and what kind of stresses are available around them that they need to be affected. So this actually helps the senior organizations and also helps the insurance companies to reduce the healthcare costs. With that, thank you, and thanks to our partners and sponsors who helped us carrying forward this research. Any questions would be appreciated.
Thank you so much, Ghanim and Maren. That was a fantastic presentation. So please, everyone, put your questions into the question and answer box, and we have a little bit of time to and we have a little bit of time to discuss. So, okay, if I don't see any questions right now, so I was just wondering, could you talk a little bit about, sorry, I just kind of switched around. Can you talk a little bit about some of the feedback that you received from the OA users?
Okay, so I can see a question if you.
Okay, we can also, yeah, absolutely go for different questions as well. So let's see. Why don't we go? Did tracking trigger any specific interventions, i.e., nurse or social worker visit? I'm just going to answer live.
I can answer that question from our housing perspective. So we offer, we don't have any forms of care involved in our housing. So it is completely independent living. So Ghanim can answer the other part, but just as a context, because we don't offer those supports, there would be no trigger from our end of triggering a care support from a nurse or a social worker.
It's, I'm sorry, so I'm like a little confused. Whose answer are we responding to? Like whose question?
I think we I'm just reading a few questions aloud that they're coming from the audience right now. So yeah. We have some other questions as well, Ghanim, if you want me to go ahead. Like, for example, one of the questions here is the study published yet?
So we have done a conference paper, and we're working on a journal one right now. So it's not published like on officially right now. We're just working for the publications.
Okay, wonderful. And then we have another question here, which is about, did any of your participants have a mild cognitive impairment? And if yes, were they able to use the app?
So in the beginning, when we were screening for the participants, we made sure that those with less cognitive abilities or cognitive impairments were excluded from the study, because we require participants to be able to use the mobile phone application and to know their destination. So the cognitive abilities were spot on when it comes to participants that were part of this study.
And as a part two to that, because it is independent living, the participants, the clients need to be able to agree and understand to the study on their own. There's no intervention from GEF Seniors Housing staff. For example, I was there, but I had no intervention in assisting people to sign up. They had to be able to ask questions directly, receive responses from the team, and sign up on their own and agree to the terms and conditions of the study.
Wonderful, amazing. And I see we have a lot of other questions, both in the chat and in the Q&A box. I would suggest just giving our time that we keep those for the final Q&A answer session and move them forward. And now we will move forward to the next presentation. And I just want to take a few minutes to introduce our presenters. We have Natalie Turam, a physiotherapist by training. Natalie worked for about 10 years in hospitals, private clinics, and rehabilitation centers before entering research 8 years ago. Natalie has a background in neuroscience and rehabilitation science. She is currently a PhD candidate in population health at the University of Ottawa. As part of her PhD project, Natalie plans to find a way to help healthcare professionals improve their attention to the comfort, dignity, and safety of older adults when using transfer technologies, as these concepts appear to be essential components of their lived experience in healthcare settings. And the second presenter we have here today is Gail Ramsden. Gail has been a resident in Pearly Health for 5 years. She is the chair of their residence council. She also serves on the board of directors for the Ontario Association for Residence Councils. She also brings the voice and realities of those living in long-term care, particularly voices of those unable to speak for themselves. In addition to the council, she serves on a variety of research initiatives and projects. She hosts webinars, bringing into focus the lived experiences of long-term care, and sits on ministry-facing committees, bringing into focus the realities and shortfalls within the LTC system. She can be found presenting at symposiums and conferences, as well as on this webinar. So with that, please, Natalie and Gail, take it away.
Yeah, can you hear me?
Yes, we can.
Sure. Thank you. My name is Natalie, and I'm pleased to be co-presenting today with Gail, a research project that is grounded in a co-construction approach to knowledge. So this project explores how we can better assess the comfort, dignity, and safety of transfer technologies. By transfer technologies, I mean the devices that we usually that help to move individuals with mobility impairment from one place to another. So as you can see, there are various technologies used for physical transfer. So you can see them on the slide. Some of them are very common: the sailing lift, the Serra Steady, and there are so many that are widely used in hospital and long-term care settings to support mobility and reduce the injury risk. So why these technologies help reduce biomechanical risk of injuries, their impact on the residents' life experience remains underexplored. So beyond their function normally, we need to ask how do these technologies impact the person being moved? How do they feel during the process? So that is where our key concepts come in. So the comfort, the dignity, and the safety. And what is known is that the perceptions of this technology, they vary greatly. So what one person finds comfortable may be perceived as unpleasant or uncomfortable by another person. So the same goes with dignity and safety of the technologies. And in the literature, the concept remain largely subjective, and that is it is very not well defined in literature. So that is where we are interested in this study to first identify the needs and preferences of older adults and staff that are the main users of these technologies, and also we would like now to translate their understanding into a form of a tool or an assessment tool that will help better define or explain the concept in an objective manner. So the question we are asking ourselves is, why do these concepts matter to this challenge area? Well, it's because they help address ethical issues of transfer technologies, and I will pass it to Gail to say something on why do the concepts matter. Thank you.
Thank you, Natalie. Okay, so the three concepts of comfort, dignity, and safety. Right now, I'm going to leave speaking about dignity to a couple minutes from now. So I'll focus on comfort and safety. And we heard Viviane at the top of this presentation talk about autonomy and independence. And I think we all can understand that transfer mobility equipment provides residents who would be who would be otherwise challenged to be able to get around. It provides them that ability. So I think that if we look then towards the comfort aspects of using this equipment, we have residents who are in a long-term care facility because they have some challenges, be they physical or mental. But I think that we have to focus on the comfort level of using these devices. And there's a matter of being made comfortable physically. And there's the additional aspect of, do you feel comfortable? Do you feel safe? Are you safe? Yes. Do you feel safe? I think that we have to focus on those kinds of things when we talk about these concepts, because the act of using these transfer devices has to be made in conjunction with the feeling of the resident while participating, as well as the ability to ensure the equipment is safe, and that while using the transfer devices, the residents are feeling safe, they're feeling comfortable. So I myself am a triple amputee, and when I use a lift system, I can feel uncomfortable, but I'm still safe. And I think we have to find a way to balance those two requirements. We have to satisfy both of those requirements, and that's the challenge. Natalie?
Thank you so much, Gail. So to address our study objectives, we conducted qualitative research with interviews with conducting interviews with residents and patients, and focus group discussion with staff to understand better their perception about the concept. And I will still invite Gail to share her perspectives again about the concept from the interview we had. Gail?
Great. Yep. Thank you, Natalie. Okay, so I promised to talk about dignity. And the first thing that came to mind when I spoke with Natalie initially, when we talked about this concept of dignity, I said to her, you know, there's such a thing as being treated with dignity and feeling dignified. And we have to acknowledge that using some of these transfer devices, such as a lift, while the staff may treat me with dignity and they do their best to make my transfer one that treats me with dignity, the reality is that if you're being lifted into a shower chair, there's nothing dignified about that. And so the ability to treat residents with dignity falls largely on the staff. How well they know the equipment, how much knowledge they have on the equipment, how they understand the requirements of me or the resident that they're helping, how they actually perform the transfer. Each resident has unique requirements, and it's incumbent on the staff to understand those idiosyncrasies and requirements. Somebody has a wound here, somebody has a limb there that is not, that they're not able to control. Somebody has a cognitive impairment and might be afraid of the lift. Those are the things that the staff need to understand about each and every resident. And what it boils down to largely, in my mind, is consistency. Having staff that are knowledgeable about the equipment, knowledgeable about the desires and the idiosyncrasies and requirements of their individual, and to help that resident as safely and as efficiently with as much dignity as they can every single time. And every single time means consistency of staff. So to me, the dignity aspect boils down to how the individual is treated and how consistently that happens. Thanks, Natalie.
Thank you, Gail. So I'll now share some preliminary analysis we conducted from the interviews and the focus group discussion. And the findings, as you can see on the table, the findings shows that the definition really vary, and the concepts are deeply interconnected. So the professionals from on their side, they highlight the importance of adaptability, good communication to ensure patient safety or resident safety. So the concepts are really interconnected, and we really need a better way to assess those concepts in an objective way. That is the next step of our project. We will still conduct a second round of focus group discussion in order to identify a better way to assess the transfer technologies in terms of comfort, dignity, and the safety. So that is where we are right now, and we will be happy to answer your questions during the, if you have any. Thank you for your attention.
Fantastic. Thank you so much, Natalie and Gail. What a engaging and great presentation. Please, we'll just give it a few seconds to see if people are posting into the question and answer box any questions you may have for Gail and Natalie. Okay, so I'm just saying, because we are a little behind time and we don't see any questions right now, let's keep those questions, have people think about any more questions for Natalie and Gail, and keep moving to Emil's presentation. Very quickly about Emil and Steadyware. Steadyware Inc. is a Toronto-based medical device company pioneering stabilization technology for individuals suffering from essential tremor and Parkinson's disease. Their flagship product, the Steady 3, is a battery-free lightweight glove that utilizes a proprietary magnetic system to counteract tremors, providing immediate and effective stabilization. So Emil leads the company's marketing and operational strategies, leveraging his MBA and extensive experiences in omnichannel sales. His efforts drive physician partnerships as well as global market expansion. Emil, please take it away.
Thanks for the intro, Viviane. It's great to be here, and thanks for setting this up. We started this company because everybody on our team had tremors in their families. My grandmother personally suffers of essential tremor, and seeing her struggle with daily activities was a real challenge. I teamed up with Mark, my co-founder and CEO, who has a structural engineering background, and derived some similarities between tremors and earthquakes, and decided to develop a technology that was very impactful and is now in the hands of both of our grandmas. Our grandmas, they're not alone. There are around 36 million people worldwide that suffer of tremors, whether it's Parkinson's, essential tremor, or many other types of tremors that are more rare. The treatments out there are inadequate, quality of life and independence are shot, confidence follows that, and daily activities become a real struggle. So typically, you go to a doctor, you get diagnosed, you try a medication, it's typically ineffective, and then the only other option is typically surgery. We think that there is actually a really big gap in the system. Even sometimes before medication, alternative devices or wearables are creating a new opportunity for a high impact treatment. As you can see here, the Study 3 would fit into that category. It's a Health Canada and FDA Class 1 device that has been validated in a study to really show improvement across eating, drinking, and writing in 84% of the population. We even tested it against sham, and we saw a reduction of 70% in the patient population that we tested. Our device is a lightweight solution. It's effective in essential tremor and Parkinson's and weighs under 300 grams or half a pound. Some of the results that you might be interested in reviewing here include these spiral tests that we perform. And you can see the results are quite significant in whether it's mild, moderate, or severe tremors. And, you know, we're presenting about the Study 3, but it's important to mention that, you know, what we're doing here is we keep making these devices smaller, lighter, and more effective. So you can see the progression of the technology. I've omitted the Study 1 because it's old news now, but it was also a much bulkier and heavier device. Our devices are all based on magnetic stabilization damping, or magnetic tune mass damping. That's how we're able to tackle a wide range of frequencies. The technology activates instantly and no calibration or charging is required. And as I mentioned before, it was derived from earthquake design. So I prepared a quick video here. It's a testimonial from one of our testers. Her name is Betty. She was actually at the last AgeWell conference in Edmonton, and I'll have her share her views on the technology here.
My name is Betty Faulkner, and I have essential tremors, which I have had since I was 25, 26 years old. As I got older and my tremors got worse, I did withdraw from things. This is so light. You have very little coverage on your hand, so your fingers are free. It stops your shaking. What really surprised me was I tried writing. I could actually write, and it's very close to my old writing. I can adjust where it sits on my hand so it doesn't have to sit by my wrist, where my wrist gets sore. I'm really, really pleased with it. I think it gives you freedom. It gives you a level of comfort that, at least that I haven't had. Wow. Wow. It's not just being seen in public as shaking. It's more what it does to you inside. You get a big smile when I'm finished because I'm happy. When you're shaking, you feel sort of out of control a bit, and getting that hand solid is a really good feeling. I haven't cooked for a long time because my tremors were so bad. Nobody wanted me using a sharp knife. My gosh, what a difference. It gives you your life back.
So it's just one of the few testimonies that are available on our website if you'd like to dive in deeper.
My name
With that, I'll conclude the presentation early. I want to open the floor to any questions. Our device is it's available for pre-order. We're expected to deliver within 30 days. If anybody in the network is interested, I've made a special discount code for the AgeWell network, and thank you to everybody who made this project and now a real company.
Thank you so much, Emil. This was a great presentation and a very convincing video showcasing how meaningful, what a meaningful difference this device can make in people's lives. So we have a number of questions for everyone, and thank you again, Emil, for making up the time that we went a little bit over. So why don't we start with a question for Emil? So we have a comment here saying, nice medical device, already US FDA and HC approved. Did you run a formal clinical trial? Do you have a strategy to direct to consumers marketing sales? Have you presented to charities like Parkinson's, ALS, MS, etc.?
Absolutely. So we ran a validation study, which we recorded and then took the footage and got neurologists to actually screen and score the results of the study. That was the most affordable way to do it at the time, and we will be expanding on a larger study in the future. In regards to tremor organizations, we are exhibiting at multiple upcoming Parkinson's and essential tremor conferences. Or movement disorder conferences, I should call them. Some of the advisors on our board sit on the American Parkinson's Disease Association's organizational board too, or the executive chairman of the Essential Tremor Foundation too, and other Parkinson's advocates, occupational therapists, and movement disorder specialists too.
Great, thanks. And just a reminder for people, we have a lot of questions here. If you could upvote on those that are most relevant to you, that'd be excellent. So here is another question. Have you considered, also for Emil, have you considered offering pilots to community service organizations and possibly volume discounts for hospitals and long-term care homes?
Yeah, that's a great question. We have a pilot program rolling out on the 1st of July. We have around 150 hospitals in the USA and Canada. Primarily movement disorder clinics that will be receiving free demonstration kits so patients can try before they buy. If anybody is interested in receiving a demonstration kit for their clinic or hospital, my email is listed here on the screen. Feel free to drop me a message and we can arrange for that. No problem. That's one of the new models that we're exploring together with the new device.
Thanks, Emil. And just one last two questions for you. Is there a way for patients to try it out first before they're buying? And what is the actual cost of the device?
Yeah, that's a great question. So its price is sitting today at around $600 US or 960 Canadian dollars. And that's because it's in the pre-order stage. Once the pre-order stage ends, that number will jump up to $800 US or around 1,400 Canadian dollars. We do offer a 30-day money-back guarantee. There is a restocking fee of around 115 Canadian dollars. So that would be the cost to try it from your home. Alternatively, come July, you can try it with a physician or movement disorder specialist in a clinic near you. And that map will be available on our website as it loads up.
Okay. Thanks. Thank you, Emil. And I think we've come to a good spot where we might be able to open it up for questions for everyone. So if everybody can join us back, Gail, and Maren, and Natalie.
Thanks.
And of course, again, thank you, Emil. It was a great presentation. Please stay here. I'm sure there might be some more questions coming up for you as well.
Absolutely.
I am wondering if, since we cut it short a little bit for for Maren and Gail, I just merged in first names, which is amazing of me. But my question is actually for Gail, which is, what was your motivation to be involved in the research and advocacy more generally?
Yeah, since landing in long-term care myself 5 years ago, because of the amputations, I find that obviously there's nothing wrong with me mentally. And so I found that I just naturally slipped into an advocacy role. I feel now that it's my job, my calling, to be able to speak on behalf of all residents in long-term care, particularly those people who don't have a voice of their own, and or in fact people who are uncomfortable speaking up, because unfortunately there still is, you know, that thought that if you speak up, you will be penalized in some way, despite the fact that it, you know, goes against the Resident Bill of Rights and all the rest of that stuff. So really, that's how I ended up advocating for residents in long-term care homes. And so anytime anyone with a project or an idea comes to me, if I feel that it is supportive of bettering the lives of residents, I'm all in. So I'm a gun for hire.
It's been fantastic to have you here, Gail, and incredible to have you on the research. I wonder, Natalie, do you want to share a little bit from your own perspective how it's made a difference to have Gail on the project?
Yeah, sure. Actually, it was amazing having Gail in the interview, because she pointed out very important aspect that I didn't see at my end as a researcher, and it's very, very important to always consider the resident perspective, because all the devices, all the technologies that have been prepared or manufactured, they are the one using it. So their voice is very important. Their point of view matters in improving the way the device is, the way the device is manufactured, and also the way the staff use the device. It really matters from the resident's perspective. Yeah. Thank you.
Thanks, Natalie. Yeah. It's great to hear your insights around the importance of working with older adults on projects like this. I also had a question that was left overhanging for, I think, where did we go there? Ghanim and Maren. And one of the questions for you that I wanted to ask is, so were those smartphones also supplied to seniors? And when scaling up this particular technology, how would you do that in terms of addressing like financial issues for many low-income seniors?
Right, so I can answer that one. So basically, for the purpose of the research, we provided the smartphones, the sensors to almost all of our participants. Even the participants who had the smartphones were like initially a bit reluctant to use their own devices for the purpose of the research, because there are lots of privacy issues and stuff. So we managed the devices for all the participants we had for the study. As for your second part about the future, if they want to use the application, I think it's just the one application that we have developed, and this application could be easily installed to the smartphones that they already have. So no extra technology is required for that. And the application does the work to help them navigate around without any hassle.
Excellent. Thank you so much, Ghanim. Wonderful. And one more question for Emil. We had somebody was asking, is there any kind of real-time tracking of symptoms related?
In this case, this is a hardware solution that is purely offline. We don't offer any tracking. It's some patient monitoring is something we will be exploring for the version 4 of the device. However, it's not something we've been tracking or exploring in this version, as it would change the class of the device too.
Okay. Oh, and one more important question for Emil as well. Someone is asking, could we have your presentation in French? Or maybe it's
I don't have a French version of this presentation. I apologize.
That's okay. Thank you. Okay, so we have reached our end mark for today's presentation, and I just want to say this was a wonderful collection of presentations and presenters. Thank you to everyone, and I wish you a wonderful rest of the day. And thank you also to the Age Well network supporters. I hope everyone enjoyed the session today.